Welcome back to My Hematology. This is where we take complex concepts of hematology and break it down to simple bite sizes for easy understanding. Okay, picture this. A lab report pops up on your screen. You scan the results, and there it is. White blood cell count elevated. Now, the patient might feel perfectly fine, or they could be critically ill. That single number isn't an answer. It's the start of a clinical investigation. It's a huge clue that the body's immune system is on high alert. So let's get into it and figure out what that number is really telling us. We're going to start with the basics. What even is leukocytosis? We'll get into decoding the different types. After that, we'll play detective and look at the usual suspects, the causes. We'll also cover the major red flags for when things get serious, and then lay out the diagnostic pathway and how we actually manage these patients. All right, let's start at square one. When we see that high white blood cell count, what exactly are we talking about?
Let's define our terms. At its most basic, leukocytosis just means you have more white blood cells than normal. But here's the absolute key takeaway. It's a sign, not a disease itself. Think of it like a fire alarm. When that alarm goes off, you know there's a problem, but it doesn't tell you where the fire is or if it's just some burnt toast in the kitchen or the whole building going up in flames. Our job is to be the firefighters and find the source. So what does high even mean? Well, it depends. Look at how much the normal range changes with age. A newborn could have a white count of, say, 30 and be totally fine. But that exact same number in an adult, that's a massive red flag. For most of what we'll talk about, we're going to be zeroing in on that adult range. So for us, anything over 11 is where the real investigation begins.
But that's just the first piece of the puzzle. The most important question is which specific type of white blood cell is causing the ruckus. This is where we start decoding the differential. The total count tells us that there's a problem, but the differential tells us who is responding. Is it neutrophilia? Those are a bacterial infection first responders. Or is it lymphocytosis, which might make you think about a virus like mono, or even some types of cancer? Maybe it's eosinophilia, pointing toward allergies or a parasitic infection. And here's a pro tip. Always look at the absolute count of each cell type, not just the percentage. That absolute number is what really guides our next steps. So we've identified the main cell type that's elevated. Now we can start building our list of suspects. It's time to figure out the why. What's actually causing this? The list of potential causes is pretty broad, but it boils down to a few key categories.
Infection and inflammation are the big ones for sure. Most of the time, the body's just reacting, ramping up its defenses. But we also have to think about things like tissue injury from trauma or surgery, certain medications like corticosteroids, and of course the one we can never ever miss, a neoplasm like leukemia. And that's really the core challenge here, isn't it? Telling the difference between a simple reaction and a full-blown malignancy. Most of the time, a high white count is pointing to something manageable, but sometimes that number isn't just a sign of the problem, it is the problem. So when do we need to start panicking? When does this become a true medical emergency? A white blood cell count over 100 times 10 to the power of 9 per liter. This is a condition we call hyperleukocytosis. And when you get to this extreme level, the sheer volume of white cells literally starts to thicken the blood. It goes from being water to being more like, sludge. That thick, sludgy blood can't flow properly through the tiny blood vessels. It starts to create traffic jams, clogging things up. This can lead to vascular occlusion, causing strokes or organ damage. It can trigger DIC and even tumor lysis syndrome.
Okay, we've covered the what, the why, and the when to freak out. So now let's get down to business. How do we actually systematically work up a patient with a high white count? The best way to think about it is like a funnel. You start really broad with your basic CBC and differential. That gives you your first clues. Then, based on that, you narrow it down to tier 2. You look at the cells yourself on a peripheral blood smear. From what you see there, you can do a more directed workup, maybe get some cultures or imaging. And only if you really need to, you move to the most specific tests at the bottom of the funnel,
like a bone marrow biopsy. And don't ever underestimate the power of that peripheral smear. It is so incredibly useful. It's not just about counting cells, it's about looking at their morphology. Do they have toxic changes that scream nasty infection? Or do you see those classic smudge cells that are a dead giveaway for chronic lymphocytic leukemia? And if you see blast cells, it could mean acute leukemia. Now, this is a classic challenge for students. You have a sky-high white count. Is it a massive but ultimately benign response called a leukemoid reaction? Or is it a cancer like chronic myeloid leukemia?
The clues are all there if you know where to look. A high LAP score and those toxic changes we talked about point towards a reaction. A low LAP score and the presence of a specific gene, the BCR-ABL1 or Philadelphia chromosome, that's CML. All right, we've made it to our final stop. We've done our investigation. We have a good idea of what's going on. Now, what do we do about it? We treat the cause, not the number. For the vast majority of cases, that high white count is just a reaction to something else. We don't treat the number itself. If there's an infection, we give antibiotics. If it's inflammation, we treat that. And if it's just stress from something like a seizure or surgery, we usually just observe because it'll come down on its own. It's all about going after the underlying driver.
But what about that emergency we talked about? Leukostasis. Well, this is the exception to the rule here. We absolutely do have to treat the number, and we have to do it fast. The approach has three main parts. First, we give the patients IV fluids to try and thin out that sludgy blood. Second, we have to get that cell count down, either with a medication like hydroxyurea or by physically filtering the white cells out of the blood. And third, we have to protect the kidneys from all the junk that's released when those cells start to die off. Unless we're in that rare life-threatening emergency of leukostasis, our focus should always be on figuring out the root cause and fixing that. The number, it's just the messenger. Don't shoot the messenger. So the next time you see that lab value, WBC elevated, I want you to remember this. The lab report gives you a single number, but your job as a clinician is to find the story. Look past the number and ask yourself, what is this patient's body trying to tell me? That's where the real medicine begins.